So to start real quick, it's kind of common for us to give a slide disclosing any financial ties. I will be talking about some devices in certain circumstances. We do not receive any compensation for talking about those devices. We do offer these procedures and implantation of them, and so that's why we're talking about them. So to start, we'll talk about what actually is GERD, or gastroesophageal reflux disease, why it is important, why does it actually happen, what's kind of the basis for why patients get heartburn and reflux disease, how we diagnose it more than just asking about symptoms, and then what treatments are available for it. So when we talk about GERD by base of symptoms, basically it's this upper abdominal or this burning beneath the breastbone that feels like indigestion, and it kind of radiates upwards. And it's actual reflux of stomach contents into the esophagus that you're feeling, and it causes the symptoms that are heartburn. When we talk about it in our world for medical definition, it's abnormal acid exposure to the lower part of the esophagus. And that's actually defined by testing for that acid. And that goes above and beyond just symptoms, because symptoms don't always tell us everything that's going on. We look at that with a pH study. The other way we look at it is actually with the scope, with an upper endoscopy. We can see injury to the inside of the esophagus from that acid, and that's called esophagitis. And oftentimes, reflux disease is associated with a hiatal hernia, and I'll get into what exactly a hiatal hernia is a little bit further down. So how big of a problem is it? Well, it's actually the most common disorder of the upper part of the GI tract. About 40% of Americans have heartburn at least once a month, and 10% of Americans have heartburn daily. The fact that you're here joining us today is a good indication that you're probably in that 10% group, or at least have significant heartburn symptoms, and you want to learn more about it. It's known to have a major impact on quality of life, as well as a cost to our medical system, with multiple millions of office visits per year, people losing time from work, decreased productivity, and all of the costs that are associated with that. In addition, there's the medical treatment costs. So back in 2008, 2009 was a big year, because they're called proton pump inhibitors, but they're the big kind of medications that are used to treat acid reflux disease. 3 of those became generic, and so the cost to patients actually went down. It was up to almost $200 a year for patients. Over the last decade, that's gone down to about $100 a year, average spending per patient to treat their reflux disease. But if you multiply that by 10% of Americans, you're talking about $20 billion a year just in medical treatment alone. When we look at quality of life, there's also a big impact, particularly in the role limitations. So whatever your role is, whether you work, whether you're a homemaker, whether you volunteer, there's a significant reduction in your ability to participate in that role. There's also bodily pain, a significant reduction in your overall pain scores. So how comfortable you are, how many symptoms you have that are causing distress. So when we ask about symptoms of reflux, the 2 primary symptoms that we're asking about is heartburn. That's that burning sensation, lower part of the belly, beneath the breastbone, that radiates upwards. It's oftentimes made worse by large meals, fatty foods, caffeine, spicy foods, and it generally improves with antacids or anti-secretory medications. So over-the-counter Tums or Rolaids or Mylanta or famotidine, which is also over-the-counter, or proton pumps inhibitors. And we'll ask you those questions about how well do those medications actually help your symptoms. But aside from heartburn, what a lot of people don't recognize is something called regurgitation. Regurgitation is actually this effortless bringing up of liquid or bringing up of even food into the base of the throat. And it oftentimes tastes like this very bitter acid taste in the back of the throat. Some of you may have experienced that. It's also common to happen with certain positions, like if you bend over to put your shoes on. that extra pressure that you have on your belly can actually force some of that liquid up into the base of your throat without you even realizing it. And it's different than throwing up. Throwing up is this projectile vomiting where your stomach is contracting forcefully to get rid of the contents. Regurgitation is effortless, and it can actually lead to respiratory symptoms, so difficulty breathing, because you can get it into your lungs, and it can even cause pneumonia. Now, as a third symptom, as an aside, dysphagia is what is difficulty swallowing. That irritation, that injury to your esophagus, to the lower part of your throat, can actually start to cause foods to get stuck and to feel like certain foods don't go down very well. And so that's another thing that we ask about. Then there's a whole nother group of symptoms that we call atypical. And the reason that we call them atypical is there is not really 100% correlation between acid reflux and the symptoms themselves, but they are known to be caused by acid reflux. So we'll ask about cough, we'll ask about history of pneumonia, sore throat or hoarseness, even bronchitis, because if you get that acid in your throat, sometime that can happen. And then we'll ask about chest pain. A lot of people don't realize it, but of people who go to the emergency room for chest pain, they get all of their heart tests done, their heart checks out to be normal. Half of those people, it's related to reflux disease as the reason why they had such severe pain that they went to the emergency room. And so we'll ask about that as well. So I have this up just to kind of give a little bit of what normal anatomy is. So we have the esophagus here going down. It's basically a tube. It has muscles in it that squeeze to help move through, but it goes from the base of the neck through the chest into the belly. There's something called the hiatus. The hiatus is the natural, normal opening through the diaphragm, which is the muscle that separates our chest from our belly. The diaphragm helps us breathe. That's where a hernia develops. And so I'll show some pictures about that as well. But this area where I have this picture, where the junction is between esophagus and the stomach, it creates a one-way valve. It's called the flap valve. So when you swallow, food goes through it, and then the valve closes, and that helps prevent reflux from coming up. Well, what happens with acid reflux disease is that valve doesn't work the way that it should. It's not as robust, and rather than helping stop reflux, it basically doesn't work for you. The actual causes of reflux disease, there are many, many different causes. Some of them, and they all play a part to it. If your esophagus doesn't squeeze normally, then you're not going to clear acid from your esophagus as easily, and you're going to have more acid sitting there causing injury. There's actually a muscle there called the lower esophageal sphincter, which is the muscle that's part of that complex that helps prevent reflux. There's a flap valve like we talked about. And then there's outward flow from the stomach. If your stomach doesn't squeeze well, if your stomach doesn't empty, food sits in your stomach longer, there's more of a chance that you get reflux because of that. And sometimes even the small intestine. If the small intestine doesn't move things through very well, you can even reflux bile from your small intestine into your stomach, which has its own set of problems with reflux disease, and then the hernias I'll talk about. When we evaluate patients, we do something called an upper endoscopy. That upper endoscopy uses a scope, fiber optic camera, goes down your mouth, down your esophagus, into your stomach. This black line is that scope. It can actually curve all the way back on itself. And that's what we see here as we're going through the junction between esophagus and the stomach, curving back on itself to look at what the valve looks like. And then we grade them. Most patients that have reflux disease have either a grade 3 or grade 4 valve, which means that the valve doesn't work. You can tell with 3 and 4, there's basically a wide open area there. And that's generally due to a hiatal hernia, which completely disrupts the normal valve. A hiatal hernia basically means part of the stomach slides up and into the chest. And that part of the stomach, even a small one, completely disrupts that normal valve. So you don't have it anymore. And that's comes to play and is important when we talk about what are the potential treatments and what surgeries we can do to fix it, because we have to fix that hiatal hernia at the same time in order to recreate that valve. And here we can see the same thing. This kind of part of the diaphragm, which is that muscle, helps with forming that valve. And so that has to be fixed at the same time that we fix the hiatal hernia. So then, now that we've kind of covered what are the different causes for it, well, what are the treatment options? Medical therapy is the mainstay of treatment. Whenever you go see a doctor about heartburn, they're going to talk to you about what the medical therapies are first and foremost. But then there's something called augmentation, which basically means we implant a device that sits where that kind of junction is to help improve that flat valve to help prevent reflux. And then there's surgical reconstructions as well, where we reconstruct that valve. So when we talk about medical therapy, the first and foremost thing is lifestyle management. So changing your diet, avoiding spicy foods, fatty foods, coffee and tea, mostly because of the caffeine that's in them, alcohol and tobacco, and acidic foods. Oftentimes patients say that tomato sauces in particular really give them bad heartburn, chocolate, and even peppermint. The other thing is weight loss. When you lose weight, there is less pressure pushing on your belly. There's less pressure pushing on your stomach, causing reflux. So even weight loss of 10 pounds can make a significant difference in improving your symptoms. We also recommend that patients sleep with their head elevated. So rather than sleeping completely flat, they sleep with multiple pillows or a foam wedge or in a recliner to elevate their head so that at night they have less regurgitation and less reflux. We also recommend you avoid late meals. So give yourself 2 to 3 hours between the last meal of the day and when you lay down to go to sleep. And it's just the same thing. If you have a lot of food in your stomach when you lay down, there's more pressure. That food has a higher chance of going back up into your esophagus and causing reflux. And even if you wear really tight clothes, you're putting more pressure on your belly. More pressure leads to more reflux. The other side of the lifestyle management is the medicine management. A lot of you are probably familiar with these different medications. So there's over-the-counter antacids. When we talk about antacids, we talk about things like Tums and Mylanta, Rolaids, Gaviscon. Those are immediate acting acid neutralizers. They work really well at the time you take them, but they don't last. And that's where things like proton pump inhibitors and histamine, H2 is a histamine receptor, and they block them. So famotidine, which is Pepcid, or proton pump inhibitors like omeprazole or esomeprazole, which is Prilosec and Nexium, those are going to last longer and can give you between 80 to 100% of complete acid suppression. Now, when we talk about prescription medications, those are usually higher doses, and there are some proton pump inhibitors that are prescription only. When we start treatment for someone who presents with bad reflux disease, we will oftentimes put them on a high dose trial of a proton pump inhibitor. That's usually a higher dose twice a day. And we'll do that for 4 to 8 weeks to see if their symptoms get better. And if they do, then we can drop that dose down. When we talk about symptom response to just medications, the reason why I have this slide, so NERD is non-erosive reflux disease and RE is erosive esophagitis, basically means injury to the esophagus. I have this because when you take medicine, it makes the acid go away, but it doesn't do anything about the actual refluxing because that's a physical anatomic problem where the valve doesn't work. And so even if you make the acid go away and the burning pain gets better, the regurgitation, the bringing up of stomach contents into your esophagus, into the back of your throat, that doesn't change. It just doesn't burn as much. And so you can still get a lot of irritation from that, even when you're taking medications. And that's one of the common complaints that we hear from patients when we see them, is they say, man, it made my heartburn go away, but I keep having regurgitation. I keep having these symptoms, even on the medication. So when do we actually test for reflux disease above and beyond just asking about symptoms? Well, one reason is if you don't respond to antacid medications or you don't respond completely. Let's say you take the medicine and you say it only works 50% of the time, but not all the way. The other reason is for what we call alarm symptoms. Basically, it's some type of sign or symptom that makes us concerned there may be something bigger going on. So if you come and say that food feels like it's getting stuck, or you've had issues of pneumonia, and they think the reason you had pneumonia was because you aspirated, you got food into your lungs, or you have low blood counts, anemia. Hernias, especially as they get bigger, can cause ulcers on the inside of your stomach, which can bleed. And that would be another reason that we would get an upper scope. Chest pain, weight loss, or rather than regurgitation, you have vomiting. And then anyone who's had symptoms for more than 10 years. And the reason for that is because those patients are at higher risk for something called Barrett's esophagus. You may have heard that term before. A lot of people get concerned about it because of the concern for cancer. Barrett's esophagus is basically normal cells, but they're in the wrong place. So as a protection mechanism, your body takes the normal esophagus cells and they look more like intestine cells because they're trying to deal with that acid injury. And that's what Barrett's is. They are normal cells that are in the wrong place. Now, those normal cells, if they keep getting injured over and over and over with acid, they can become abnormal. And that's when they become precancerous. And so if you've had symptoms for more than 10 years, we do recommend that you at least get an upper scope to have that checked out to look for that, for Barrett's esophagus, or in some patients, even esophageal cancer. So when you come to see us, one is, so EGD is just the upper endoscopy. It's a fiber optic flexible scope. You come in, it's a same day procedure. Basically, you get some sedating medicines, and while you're sedated, we go down and we take a look. Another study we get is called a video barium swallow study. It gives us a lot of information about how you swallow, how your esophagus functions, and whether or not you have a hiatal hernia. Then we also get that pH testing. The way that we test for acid is one of them is a little capsule that clips to the inside of your esophagus that measures acid, and then it wirelessly connects to a monitor you wear around your neck, and you press some buttons when you have symptoms. And it will record acid exposure, and it will time it with your symptoms. And that gives us a lot of information about when you are feeling heartburn, are you having abnormal acid in the lower part of your esophagus? And that's kind of the biggest study that we use to know, is the amount of acid that you're experiencing normal or abnormal? Because remember, it is normal for some people to get a little bit of acid exposure. And we want to know, is it normal or not? And then there's something called esophageal manometry. This manometry basically is the study of how the muscles of your esophagus squeeze. It's a probe that goes in your nose all the way down into your stomach. Every centimeter, it has a little tiny pressure sensor. Then you take a bunch of swallows, and it will measure all the way down how good of a squeeze your esophagus has. And we want to know that, one, because it can help us identify potential causes for your symptoms, but also when we're talking about treatment, there are certain treatments that you need to have above a certain level of swallowing function in order to be a candidate. So why would we ever offer someone surgery or some type of procedure? Well, the very clear-cut reasons are if you have acid damage to your esophagus that does not heal despite medical therapy. So that would be esophagitis, injury to the esophagus that doesn't fully heal. Another one would be aspiration. If you're having pneumonia because you're aspirating from regurgitated food and getting it into your lungs, well, that can be life-threatening. So that would be a reason to have that hernia fixed. Or if you have a large hernia and that hernia is causing blockage, it's twisting on itself, It's making it so you can't eat and you're losing weight. That would be another reason to have it fixed. Other strong reasons would be if you try the medicines but you can't tolerate them, either because of allergies or side effects, or they just don't work for you, or they only work part of the way. Or if you have Barrett's esophagus, the mainstay of treatment for Barrett's esophagus is actually medical therapy to reduce your acid exposure. But if you're on appropriate medical therapy and the Barrett's is not going away, that may be a reason for surgery. Another reason is young patients who are dependent on their medicine to function. Now, that's not to say older patients who are dependent on their medicine to function aren't also a candidate, which they are. But if you're 20 and you have another 60 plus years in front of you and you're taking daily medication, well, that's a long time to be on a daily medication for acid suppression. So that brings us, the most common reason we end up doing surgery for patients is for quality of life, as an alternative to the medicine that they're on right now. And it's because their medicines are not working, they don't want to take them, they've been on it for 20 years already, and they hear things about increased risks for cancer or Alzheimer's or all those. Well, those medicines are very well tolerated. They are very safe to take for many, many years. And although there is some kind of inklings of association with those other things, some patients really don't like that. And so that's one of the reasons why they come to see us. And if that's one of the reasons why you're here, it is a reason why we offer patient surgery. They want to be able to stop taking that daily medication. And for the vast majority of patients, that's what we can offer. So the anti-reflux procedures, when we talk about whether or not you're a good candidate, the things that we're looking for is, do you have a response to antacid medications? If you do have a response, that's a good sign, because that helps us correlate. If you have acid reflux, you take antacid medications and your symptoms get better, it tells us that your symptoms are more likely as a result of your acid reflux. So if we make it go away with a surgical procedure, we can be more confident that a surgery is going to help you. We also look for those typical symptoms, so heartburn and regurgitation. Now, that's not to say someone who presents only with cough, which we do have patients where their only presenting symptom is a cough. It just means we have to do extra work to investigate that cough to really prove that it's because of acid reflux, as opposed to some other reason like postnasal drip or sinus infections or something else that could cause it. And then we do pH testing, where we actually get a score called a Demeester score that helps us know whether the amount of acid exposure you're experiencing is normal or abnormal, and how it corresponds to your symptoms. I'm going to talk about a few different types of procedures, going from least invasive to most invasive. Those are scope-based procedures, augmentation, and then what is now considered a more traditional surgical repair, but those have been around for more than 40 years, tried and true, and work very well. So the first one is called a transoral incisionless fundoplication, or TIF. It is a device that goes over a scope. So it's a scope-based same-day procedure, so you go home the same day. It creates that, it's called a fundoplication. What that means is it just recreates the flap valve, and it uses permanent fasteners to do it. For patients that do not have a significant hernia, because remember, a significant hernia is part of the reason why you have reflux. And if you don't fix that hernia, a lot of patients, the reflux doesn't get better, even if you try and make their valve better, simply because over time that valve then gets destroyed because the hernia keeps pushing on it. So in patients that don't have a hernia, BMI less than 35, these are indications by the manufacturer for this device. And that's because patients that have more weight tend not to have as success after the procedures. And that's why that's there. And then you can't have any narrowing of your esophagus or ulcers there because the device has to physically make it down. So this next part is actually a video of that TIF procedure. It goes down your esophagus into your stomach. Here's where that device folds back on itself, and we have that black line as the scope. That device will then catch part of the upper part of that stomach right at the junction, pull it down into where the device is, and then that device will fire, and it fires these permanent fasteners. Those permanent fasteners then recreate that flat valve. What's nice about this device is that there's no incisions. It still can have some pain because it's firing these fasteners through the tissue, but by and large, patients have a faster recovery. By and large, it's easier on them. They don't have incisions. They're able to get back to work faster. And overall, and that's how it recreates the flat valve right there. And overall, that's what the benefit is. Now, unfortunately, there's also some downsides. Here's just some pictures kind of in the operating room of what it looks like. Here's the device. It catches the tissue, pulls the tissue up. You close the device and then place the fasteners down. So it does improve symptoms. So this is quality of life scores. Basically, it means how much does heartburn affect your quality of life. A higher score means it makes your quality of life worse. So we have improved scores for quality of life after this procedure. And we're able to get patients off of their antacid medications about 70% of the time. But that means about 30% still require antacid medications. And there are about a third of patients that will then go on to have additional treatment. Very rarely there's bleeding or there's injury to the esophagus as a complication, but that's very, very unlikely to happen. So the good part is that it is relatively quick, relatively straightforward recovery without surgery or incisions or some of the activity restrictions. The downside is it doesn't seem to work quite as well as the surgeries that we offer. More patients are still on their antacid medications, and it tends not to last quite as long. So this data is from 3 years. When you get out longer to 5 years or more, the number of patients off of their antacid medications falls further to about 50% at 5 years. So generally, when I talk to patients about this, and if we're considering it as an option, they should expect that it'll last them about 5 years, maybe up to 10 years, but it tends not to last as long as the other options that we have. And so that's the downside. The next one that we talk about is called sphincter augmentation. The name of this device is actually called the Lynx, L-I-N-X device. It is a ring of magnetic beads. Those beads are linked together by these titanium linkers, and it's got a titanium shell around those magnetic beads. Those beads have a certain force to them that wants them to attract to one another and close. That force has been engineered and designed to be the right amount of force to prevent reflux. So if the stomach has pressures somewhere in the 5 to 10 range, the Lynx device stays closed with a force of about 20. A normal swallowing force is somewhere between 35 and 80. And so you can imagine when you swallow, your esophagus generates enough force to open the device. Food goes through into your stomach like normal. But the stomach itself, you can't reflux because it doesn't generate enough force. Well, the good thing about this device is it most closely approximates normal function of anything that we offer. And that's because it opens and closes based on force, just like a normal valve would. If you had to throw up, your stomach would generate enough force where you could throw up and the device would open. If you had to burp and you had pressure in your stomach, you can generate enough force where you can burp. This device has been around in the United States for about 11 years. It's been used in Europe for about 13 years. So that's the downside. No one can tell you, well, what is this device going to look like and function 30 years from now? Because it hasn't been in existence that long. It's designed to be lifelong. It's designed to be there to function for your entire life, but no one can tell you exactly what's going to happen. So there is a low rate of having the device removed. It's about 3 per 100. So about for every 100 that we put in, about 3 of those people will decide to have that device removed. Either it didn't work for them, which is the vast majority, or they had side effects from it, which is primarily their swallowing mechanism couldn't generate enough force to get it open, so they feel like food gets stuck and they have trouble swallowing. Part of the way that it works is that normally when you eat and your stomach distends, it gets bigger to fill with food. When it gets bigger, it causes the normal valve to shorten. Well, when you put this device there and it adds that pressure, that prevents the valve from shortening and augments. It makes the valve that you have work better. And at the same time that we would implant this device, if you had a hiatal hernia, we fix the hiatal hernia at the same time. And this was what it looks like in the operating room. So it's this ring of beads. It sits around the lower part of the esophagus. This line coming through here is the esophagus. Someone has an instrument here lifting the stomach up here, and this is where it's resting. It's sitting around the esophagus. Liver is off over here to the side. Up here is diaphragm, which we talked about, makes up the hiatus. And then down here is stomach. This is what it would look like from the inside. So a scope going in, turning back on itself and looking, and you can see that that ring of beads is nice and tight around the scope. And this would be what we would call a grade 1 valve. It's basically made their valve look like normal. So if we talk about pH tests, so studying the acid test after you've had this device, about 2/3 of patients will have more than 50% reduction in the acid to their esophagus, and 58% of patients, their acid exposure will then be normal. That being said, when you actually talk to patients, 94% of them were satisfied with the results of their symptom control after their surgery, and they had improved quality of life at 1, 2, and 3 years afterwards. Now, as I said, it hasn't been around for more than 11 years, so we don't have that kind of 10, 15, 20-year information like we do for some of the other procedures. And then this just talks about, so able to get off of proton pump inhibitors, about 85% are able to get off. About regurgitation, those are almost all gone, or at least very mild. And then when we talk about difficulty swallowing, that's one of the downsides, is immediately after the device is put in, about half of patients will have some feeling of difficulty swallowing. And that's simply because your body and your esophagus is getting used to it. But as you go longer, as time goes on and your body gets used to it, that goes away. So by the time you get to about a year, that's down to about 5 to 10% of feeling like things are getting stuck. The next kind of things that we talk about is surgical repair. So what are the goals of any surgery? One is, well, we fix the hiatal hernia. We close that hiatus to make it more snug around the esophagus. We need to get length to bring your stomach back into your belly if part of your stomach is in your chest. And we want to reestablish that anti-reflux barrier, which is that flap valve. And the way that we do that is something called a fundoplication. Fundo for fundus, which is part of the stomach. Plication means to wrap around. And so we take part of your stomach and we wrap it around the esophagus, which accomplishes something similar to what that Lynx device does. And we can either wrap it completely around, or we can wrap it part of the way around. And whether or not you're a candidate for one or the other, some of that's based on swallowing function, some of it's based on preferences and your goals with treatment. And that's something that you would have a discussion with us about prior to a surgery. So what would you want to, what to expect with a surgery? So we can do these operations laparoscopic. Laparoscopic means small incisions on the belly. We use gas to blow the belly up so we have a plate so we can see and operate. We can do that in about 99% of cases. Very, very rarely do we have to do a big open incision on the belly or a big open incision on the chest. And in almost all of those circumstances, the reason why is because they're a one-time redo or a two-time redo or a three-time redo operation, and that's the reason why. The vast majority of patients go home after just one night in the hospital. Some patients can even go home the very same day. And that was one of the ways that we were able to continue to do these operations during the COVID surge, when elective procedures like this were being postponed and delayed. Well, if we could do the operation and get someone home the same day, then we could keep doing them. So for select patients, that may even be an option. We have you up and walking the same day of surgery. You are going to need some pain medicine afterwards. You had a surgery, you're going to have some discomfort. It's very common to have shoulder pain. It's very common to feel pressure beneath the breastbone, and that's related to actually the gas irritating the diaphragm and irritating the center part of the chest. The belly pain, it just feels sore. And usually you need a little bit of a narcotic pain medicine for just a few days, and then usually just Tylenol or ibuprofen after that. You're on a full liquid diet for 2 weeks. That includes smoothies, shakes, anything you put through a blender. You're on soft food for 4 weeks. That's anything you could mash with a fork. So mashed potatoes, soft flaky fish, ground beef like a hamburger helper. And then for activity restrictions, there's no lifting more than 10 pounds for 6 weeks, no lifting more than 20 pounds for the next 6 weeks. And it's not so much because of the incisions on the outside of your belly, but it's because of the fixing the hernia on the inside. We really want to reduce the pressure against that hernia repair so that it lasts you a long time. This is what it looks like on the inside with a laparoscopic view. That is the opening up and into the chest through the hiatus where part of the stomach has gone up there. You completely lose the normal barrier to reflux when that happens, and we fix that at the time of surgery. This is what it looks like once it's dissected out. You can see the two edges of the diaphragm here. This is the esophagus up here, and then we close it. When we close it, we put sutures together, and that closes that diaphragm to make it more snug around the esophagus. And then we do some type of wrap. A toupee is just a partial wrap. Partial wraps are used when patients have difficulty swallowing because it isn't all the way circumferential around the esophagus. That's what it looks like inside a patient. And then there's a Nissen, which is the complete wrap. We take the stomach, we wrap it completely around the esophagus, and we suture it to itself. And then sometimes we will even do what's called a hybrid. If we have concerns where the esophagus might pull the stomach back up into the chest, we'll talk to you about doing a hybrid repair where we add some extra sutures to try and fix everything in the belly to prevent it from going back up and into the chest. So when we talk about outcomes, when we compare surgery versus medicine, long term, there really is no difference in the difficulty in swallowing, and that's because acid injury or reflux of even non-acid contents into your esophagus can cause difficulty swallowing. So there's no difference between the two. But there is a short, medium, and long-term meaning longer than 10 years, improvement in heartburn symptoms with surgery compared to medication. There's an improvement in regurgitation symptoms compared to medication, which you would expect since the medication doesn't affect that. And there's an overall improvement in the quality of life that patients experience. So the pros of surgery is it gives the opportunity to make life normal again. And the reason why normal is in quotes is because you develop a new normal. It's not the same as your old normal, but your new normal doesn't involve daily heartburn symptoms, and for the majority of patients doesn't involve daily medications to treat it. But you will have some sensations of food being slower to go through because we're reconstructing something. It's very different than, say you come in, you have a gallbladder problem, you take the gallbladder out. Well, the gallbladder is gone. For us, we are trying to rebuild a function, and rebuilding that function, it's never perfect for every patient because we can't predict how patients heal. Even if you have a perfect operation, how you heal may be different than how someone else's heals. And so we can't 100% guarantee the best results for everyone. But we know that the vast majority of patients are very satisfied with their results, and they're able to stop their daily medications. Now, there is a very, very low risk of even death with any type of operation. We're talking about less than 1 in 1,000, so exceedingly low, but not zero. Also short-term, there's activity restrictions, there's diet restrictions. Most patients lose 10 to 15 pounds after surgery because of those restrictions. Most patients don't mind that, and they can use it as a springboard to even lose more weight. Long-term, depending on the type of procedure that you had, it can either be hard to burp or belch, or the expectation is that you cannot burp or belch. And you can imagine if you can't burp, but you have gas in your stomach, it can make you feel bloated. It can give you some crampy abdominal pains. And all patients should expect that they're going to pass gas more, flatus, fart more. To be frank, it just happens more because you're not burping as much, more gas goes through you. And that does catch some patients by surprise, so we try and warn them. And there is a chance that a hernia comes back again, or the valve over time gets distorted. And that's largely because the underlying cause as to why you developed a hernia in the first place, why you developed heartburn in the first place, I am not changing. I'm not changing your age. I can't make you younger. I can't change your gender. It is more common in males. I can't change your weight. So I can't change your genetics. And all of those are factors as to why you developed this in the first place. Those factors are still working on our repair. And so that repair over time may not work anymore. And it's not because the repair wasn't good to begin with. It's just that your body over time changed and affected that repair. But by and large, when we do an operation, we expect patients to get at least 10 years, if not longer. And the vast majority of patients do get that amount of time out of these surgeries and these repairs. So reflux disease is very common. It's not life-threatening, but it does have a major impact on quality of life, on lifestyle, on your activity. And the primary treatment is medicine and lifestyle changes. If you haven't tried those, then that's the first thing we're going to ask you to do before we ever talk about surgery, is you have to try those first. Because for some patients, that may be all they need, and then they're happy with their overall improvement in their symptoms and never want surgery. Antacids reduce acid, but not the actual regurgitation. And overall, proton pump inhibitors are safe, but there are some long-term concerns. And there's a broad spectrum of what we can offer. Everything we offer has benefits, it has downsides, it has risks. There is no perfect operation. If there was, there would be only one, and I'd be talking to you about that one operation, but there's not. And so how we choose which one to do for you, part of it is what you bring to us in terms of what your swallowing function is, but a lot of it is based on what your goals of surgery are and what you want to get out of it. And so to end, I talk about the therapy gap. So there's more than 20 million patients that are on chronic antacid medication with PPIs. About 2/3 of them are happy with that. They continue doing that. But about 1/3 of patients are not happy with their response. And yet less than 1% of patients ever go on to get a reflux surgery. So there's a lot of patients out there that are not happy with their antacid medication, where a surgery could really give them significant benefit, but they just haven't seen a surgeon. So the fact that you're here online with me, listening to me talk, that means that maybe you're one of those people that an operation makes a lot of sense for. And hopefully we can answer some of your questions.
Thank you, Peter. Nice job. Always good to listen to these talks on reflux. There are several questions, and why don't we just go through some of them? Will ranitidine make a comeback?
I don't think so, because it's been taken off the shelf. So likely it'll stay with famotidine or cimetidine. Famotidine is Pepcid, and then cimetidine is another one. They're both H2 blockers, those are antihistamines. They actually work differently than proton pump inhibitors. The antihistamine blockers work on the pathway that promotes acid secretion in the stomach. The proton pump inhibitors actually directly bind to the pumps themselves, which is why you can actually take both of those medications at the same time. You can take a proton pump inhibitor and you can take a histamine blocker at the same time because they work differently. And in some people, they find that that improves their symptom control.
And Pepcid is the same class as ranitidine, as you
Correct.
said.
Yeah.
So, isn't acid needed for healthy digestion?
So normal acid is part of our digestive process. It is not absolutely needed, as the millions of people who are on antacid medications can attest to. It's not that they're not absorbing food. It's not that they're not healthy, but it is our initial, well, the initial is actually saliva in our mouth, but it's one of the secondary stages as to where acid combined with the turning mechanism in our stomach helps us digest food. That acid, the moment that it gets dumped into our small intestine, gets neutralized because our small intestine cannot handle that acid. And so once it passes out of the stomach, it all gets neutralized anyways with similar effects. But what it does do is it also is one of our initial barriers to bacteria. That high acid kills most bacteria, which is why there is an association with patients on antacid medication and pneumonia, because if you were to regurgitate and get some of that gastric stomach contents in your lungs, it tends to have a higher content of bacteria in it, higher chance to get pneumonia. There's also some association between C. diff. Clostridium difficile is an infection of the colon, and patients that are on antacid medications are at a higher risk of developing that infection for a similar reason that they lose that initial kind of acid barrier. I know that only partially answered that question.
Yeah, and I certainly think that being a longtime user of an antacid definitely will change our microbiome or our gut bacteria. I don't think there's any doubt about that.
Yeah, that's correct.
But what that means for us as patients, in the significance of that, I think is still to be determined. All right, so staying on the proton pump inhibitor topic, is long-term proton pump inhibitors associated with bone loss, and should we be taking supplements such as vitamin B12?
Yeah, so it has been shown that the proton pump inhibitors affect how your body absorbs calcium. And your body needs some of that acid in order to absorb calcium from the foods that you eat. So for certain patients who are already at higher risk for osteopenia, osteoporosis, adding a proton pump inhibitor on top of that may increase their risk for that. And it's not that it causes you to lose bone density, but you're not absorbing calcium as well. And so for the average kind of 30-year-old person, it's not a risk. But for a woman who's postmenopausal in her 80s and she's been on it for 20 years already, yeah, there is an increased risk for osteopenia or osteoporosis. And supplements can help with that. It's not B12, so it'd be vitamin D and calcium, vitamin D and calcium together to try and overcome some of that decreased absorption. But you can't make up for it completely. But one thing I did want to mention regarding bone loss is there are some patients that are on Fosamax or some other medications to improve bone density. If you get a fundoplication or other procedure, then you have to stop that medication, because if that pill gets stuck there, it can actually burn and cause injury to the esophagus. But obviously that would be patient specific.
So one individual had a physician tell him that a fracture in his back was related to long-term use of omeprazole. And is that a good reason to consider a procedure like you've described?
Yeah, I mean, if you are having bone fractures because you have decreased bone mineralization and you're on a chronic daily PPI, yeah, we see a lot of patients that come to see us for that exact reason. And as long as we can demonstrate that the symptoms you have are truly because of acid reflux, then yeah, it makes a lot of sense for that patient to have a procedure.
A couple of questions about links. Does links cause the same issues post-surgery as surgery? And by surgery, I think they mean the fundoplication.
Yeah, so that is one of the benefits of the LINX device compared to the fundoplication, is that patients can burp and belch afterwards. They can throw up if they absolutely had to, compared to a complete fundoplication, which is the Nissen, where we tell patients that they should expect that they cannot burp or belch, cannot throw up. If you got sick and you had to throw up, it's actually just ends up being dry heaving rather than throwing up. So that is one of the clear benefits of the LINX device. One of the downsides of the LINX device is the higher rates of feeling like food gets stuck. And that's simply because if your esophagus can't mount enough force to get it open, then it feels like food gets stuck. And for some, it actually can get stuck. But prior to being a candidate for the LINX device, we do that manometry study, which looks at the esophagus function to make sure it is above a certain level to be a candidate. And then since we're talking about the LINX device, I do want to mention the LINX device is not covered by Medicare. It is covered by private insurance companies, but those private insurance companies take anywhere from 3 to 6 months on average to give approval for it. And not all of them do give approval for it. Unfortunately, the state of Washington in relation to insurance coverage for that device is not great. There's some other states where it's much easier to get coverage, but unfortunately, it can be a challenge for some patients here.
So staying with LINX, can LINX be performed successfully without hiatal hernia surgery?
Yep. In patients that do not have a hiatal hernia, then we do not go into that hiatus area. We don't dissect it out. We only dissect right around the esophagus and then place that device. It is a much more kind of limited type of operation. And generally those patients go home the same day. That's kind of our standard pathway for those patients. Now, if you have a hiatal hernia, we have to fix it at the same time, and we will. And for patients who have large hiatal hernias, unfortunately, they are not candidate for the LINX as of right now. And that's because there's some data saying that it doesn't work as well for them. That's in the process of being studied. But for us in our group right now, we don't offer the LINX for patients that do have large hiatal hernias.
Does the LINX ever break?
It does not. So it's had multiple iterations over its tenure. From previously, it was just a suture that was tied. Now it's a locking mechanism. It's a titanium ring, and these titanium linkers cannot break under any type of normal forces. Generally, if something bad happens to the LINX device, it can actually cause injury to the esophagus. Very, very rarely does that ever happen. It's on the order of about 2 per 1,000. So very rarely, but not zero. And since we're still talking about LINX device, the other thing is it is MRI compatible up until a certain strength of MRI machine. So currently in the US, that means it is compatible with about 80% of all MRI machines. And so if you just needed a standard shoulder or back MRI, it's not a problem. But if you needed an ultra specialized specific MRI to look at one tiny part of your brain that needed a very, very high powered MRI machine to do it, then unfortunately you couldn't get that MRI. Or we have had a few patients where we've removed their Lynx device because they needed to get that MRI for other health reasons.
Really quickly, I just want to let everybody know we can take questions for about 15 more minutes. For those who have to go now, I'm going to enter the phone number for our nurse navigator for those who would like to follow up with Dr. White or one of our surgeons in the clinic. So I'm going to enter that now, and we can take questions for about 15 more minutes.
Thank you. Is the first procedure reversible? I think that's the transoral, the TIF, the transoral incisionless fundoplication.
Yeah, the sutures are permanent. I'm not sure exactly what you mean by reversible, as in you would take everything down. Generally, we don't. Usually what happens is if it doesn't work, because the valve kind of becomes distorted again over time, then we're talking about a redo operation. Redo operation in that setting can be done. There's a little bit more scar tissue, but it really doesn't change the complexity or difficulty too much. And so we can do an operation in that setting. I haven't ever heard of a patient needing their TIF taken down and removed, or not removed because there's nothing to remove, but taken down or reversed, because that's generally not a problem.
Does Barrett's esophagus preclude any of the procedures that you described?
Yeah. All of these are great questions, just like this one, and no, it does not. Severe esophagitis does. So if it's very severe, we have to get the esophagitis healed before we'll do an operation. But for Barrett's, it doesn't. If you have Barrett's, what we do though is we will keep you on your proton pump inhibitor medicine. And it's kind of like a double protection, surgery plus the proton pump inhibitor medicine to try and get that Barrett's to heal. And a lot of times it can, but then we also have to repeat your upper endoscopy, your upper scope, to look for the Barrett's. And there is a kind of set regimen of how often we look for the Barrett's to make sure that it's either getting better or going away, or making sure that it has not started to develop precancerous cells.
You know, there are a couple questions here. I'm not sure they're actually related to reflux per se. They may be related to other disorders of the esophagus. One is about food that's being properly chewed but stops before the stomach. It comes back up to the mouth. So
okay,
there are some diverticula or other problems like achalasia. And so we will not get into that, since I think that's a different topic. Somebody wants to know if there's a potential association of halitosis with long-term reflux and proton pump inhibitor use at high levels.
I have not heard halitosis for just proton pump inhibitors. Usually when we hear about halitosis, so that's, for people who don't know, that's really bad breath. We start to think about other esophageal problems, either like achalasia, where food gets stuck and the food actually ferments inside the esophagus, or something called a diverticulum, where part of the esophagus pouches out and food gets stuck into that outpouching, and then that food ferments and then causes really, really severe bad breath. But I haven't run into patients where proton pump inhibitors have been causing that.
There's another question about strictures, but related to after achalasia. And so I think we will not get into that too, since it's a different topic. Can you lose your voice because of increased acid in the throat?
Yeah, so you can. There's actually a term for that. It's called laryngopharyngeal reflux disease, or LPR. And that's where you actually reflux high enough that you get it above the other muscle, so the upper muscle, and into the throat. It can irritate the vocal cords. It can cause you to get hoarseness. It can cause irritation to the voice. It can cause coughing. So it can cause those things, but it's not the only cause. And so for patients who come in with that as their primary concern, it takes a lot of extra tests and studies to really try and sort out what's going on so that we can really prove as best we can that it is acid reflux and that an operation would be helpful.
So on a similar topic, symptoms involving the throat or maybe the tongue with a history of hiatal hernia, but no specific heartburn or regurgitation. So can you have symptoms up in your throat without having classic heartburn and regurgitation?
Yeah, so symptoms in the throat, one of the terms that we use is called globus, which is the feeling like something is stuck in your throat. Usually it's not something actually stuck high up. What happens is something gets either delayed or stuck as it's going down through the lower part of your esophagus, but that part of our esophagus doesn't have nerves that really sense that as well. It senses stretch and it senses other things, which is why if you took a big gulp of water, you can feel it as it goes down and feel that stretching sensation. But if something's getting stuck lower down, you can actually feel it like something stuck high up in the throat. I know that only partially answers that question, but
Well,
it is possible.
It's a pretty
to have
complex
symptoms lower
question.
down. It is.
Once you start getting deeper into it. Well, with that, I think we should conclude. Thank you, Dr. White, for your time and the talk. And certainly thanks to everybody for spending some time with us. And hopefully this was helpful for you as you are thinking about some of your symptoms or some of the symptoms of a loved one, or the medications or how the medications affect you. I know that Emily put the number of our nurse navigator for those of you who are asking about next steps or how to get a consultation or talk more about your symptoms. We'd be happy to see anybody to explore that. And I hope this was helpful for you. So thank you for your time.
Yep. Thanks, Alex, Dr. Farvar, and thanks everyone for joining us.
Have a wonderful night, everybody.
Thank you so much. Have a wonderful night, everyone.
Thank you.